Welcome to another episode of MedTalk. Today we have special guest Dr. Amit Chakroborty, who is a board certified practicing urologist in Missouri and also actively involved with American Association of Physicians of Indian Origin, API, for the past 15 years and is a current secretary of API. Today we will talk about prostate cancer, low testosterone and infertility in men, benign prostatic hyperplasia, and other urological disorders pertains to man, which has not been talked a lot. Welcome, Dr. Chakraborty, to MedTalk.
Thank you very much, Tusharji, for having me here. Thank you, IndusTV. I'll be glad to answer all those questions and myths and debunk some myths about all the urological diseases by men. And a lot of things are taboo and not covered usually and not talked about. I would be glad to shed some light and answer those questions which you have, and hopefully the public will gain from this.
Oftentimes, women are blamed for infertility. Is that always true? And how common is male infertility? What are some of the common causes of male infertility?
Well, that's a good question. A lot of people say that yes, a woman 50. There is a saying. There is a very generalization. This is not the exact numbers. They say 25% of the problem is with women only, 25% with males, and 50% is a combination of both. So that's a very generalization of that. There may be accurate numbers, but this is what I usually tell my patients. Having said that, male infertility can be caused by various reasons. If you have had mumps as a child, it affects, you can get a mumps orchitis, and you can get problems with infertility. There are a lot of medications, chemotherapy can give you infertility. Varicose veins, which are varicoceles, which are dilated veins in the cord of the testicle, if they are there, that can cause infertility by increasing the temperature of the testicle. Spermatogenesis, or production of sperms, they like about 2 to 3 degrees cooler than the body temperature. That's the reason in men we have testicles in the scrotum. That way they can remain slightly cooler. When there is dilated veins, it brings the same temperature to the testicles, and so there is a decrease in spermatogenesis and the quality of sperms. And there are a bunch of other causes. Stress can cause it, high fever. I've talked about medication. Now, this is something which I want to now emphasize for the primary care physicians and for the people out there. Testosterone treatment can cause lowering of sperm count, and occasionally it is irreversible. So, if you're a primary care physician and you're going to start testosterone on a person who is planning to start a family, their sperm count can go down. Be very careful, because sometimes it doesn't come back, and that would be quite disastrous. There is a myth, and it's not a myth actually. The same corollary, that if you take real hot baths, steam baths, sauna, or wear a tight underwear, keep making your testicle hotter. That may also decrease spermatogenesis. That is also traditionally, people used to advise that if you're wearing tights, wear boxer shorts. That gives the sperms a little bit better chance of production. So that's also there, and that's another cause, maybe increased temperature in the scrotal area.
So then how do you treat men who present with infertility?
So if the patient comes with infertility, you first find out whether the patient has a varicocele. That's most common reversible cause of infertility. If you find a varicocele, you clip the veins, and it's an outpatient surgery. And I've seen plenty of cases where the spermatogenesis returns to good normal values. Having said that, there are depends whether the patient has oligospermia, which is low sperm count, or azoospermia, which is no sperm count. So oligospermia, when you have low sperm count, and you have tested the female and there is no abnormality in that, then you can actually try to do several in vitro methods. One is called IUI, where you take the sperm, concentrate it, and inject it into the uterus called intrauterine insemination. You can, if the patient's sperm count is still further low, you can do in vitro fertilization, which we call cytoplasmic sperm injection, where we actually take the ovum and inject a sperm into the ovum and fertilize it in vitro, make it into an embryo stage, and implant it back into the uterus. So those are the patient who has got complete azoospermia or no sperm. You can do a testicular biopsy to see if there is any evidence of spermatogenesis. If there is no evidence of spermatogenesis, you need to think about doing genetic studies to see if there is any chromosomal abnormality, Klinefelter syndrome and other abnormalities. You need to make sure that they don't have that. Otherwise, artificial insemination donor or adoption is the way, or surrogate pregnancy or adoption is the way to go.
So, Dr. Chakraborty, we know millions of people got COVID infection since last year. Can being infected with COVID-19 lead to male infertility? Is that a possibility?
That's a good question. We have got some studies which are coming out which say that there may be some infertility in it. We don't have long-term studies to prove that yet. I'm sure within the next year or so, we will get more idea about that. Um, we know that the COVID does not usually affect the reproductive and the urinary organs quite very frequently. Very rarely we have seen COVID being spread by semen or urine. That is the reason why I don't think that will happen. However, COVID having this high temperature and having other general metabolic consequences can lead to a generalized suppression of any actively replicating cells, and that way can affect spermatogenesis.
So let's talk about the low testosterone in men. How common is that? And what are the symptoms and signs of men suffering from low testosterone? How do they diagnose that?
Low testosterone is believed to not quite common. 40% of men above 40 years, there have been some studies which show that they may have low testosterone. Now, low testosterone, previously what used to happen, there was a testosterone boom say about 10 years ago. People used to get testosterone, and that was one of the, there was even a cover in Time magazine which said that testosterone, people used to just take testosterone even if they're slightly low, and that used to give them virility, like make them muscular, and reduce their waist size. So people were very happy. Then there was articles which showed that there were cardiac side effects, and then it has stopped. So the reason I'm giving you this prelude is the level of testosterone. Previously, even 330 was considered low testosterone. After all the FDA concerns, which I'm going to talk to you in just a minute, FDA concerns about testosterone therapy came around. Now, the low testosterone level actually, according to labs, have gone down to 270. But according to the American Urological Association, we still consider below 300 to be low testosterone. How do we diagnose it? Well, very easy. We do a blood test, and it has to be a morning testosterone. According to FDA guidelines, we have to check a morning testosterone twice. So to diagnose hypogonadism, which is low testosterone, they have to have symptoms of hypogonadism, which is loss of libido, tiredness, fatigue, once you sleep, going to being very tired, going to sleep, sleep apnea, stuff like that. There are a lot of testosterone hypogonadism effects, and if you may have one of those or few of those, more than two of those, erectile dysfunction also, and you have to have two morning testosterone which have been shown low. Why morning? Because testosterone has a circadian rhythm. That means it's high during the morning, low during the late afternoons. So to diagnose low testosterone, you have to diagnose low testosterone twice, two morning samples. In addition to that, before starting them on testosterone therapy, which I'm going to talk to a little bit, we also do a CBC, lipid profile, PSA, and BMP we sometimes do, but those are on LH and FSH. LH is just to find out whether it is primary or secondary. In other words, is it due to problem with the testicle or problem with the pituitary gland, which is telling the testicle not to produce testosterone, or the hormone which tells the testicle to produce testosterone is low. So to find out whether it's primary or secondary, we do the LH and FSH. So let's recap. A person comes to you, says that, Doc, I have all these features. I've got this in a chart in my office, and they said that, look, I'm grumpy. My wife says I snore a lot. I'm grumpy. I'm gaining weight. I'm tired. I have loss of libido, erectile dysfunction. I've got all those symptoms. How do we diagnose it? Okay, we say, all right, we do a rectal exam to make sure he doesn't have a hard prostate or suggestive of prostate nodule or anything like that. And then we send the blood for testosterone. If the testosterone comes to be less than 300, we repeat a morning testosterone, and as repeat time, I do a PSA, CBC, lipid profile. Just now I said, and LH-FSH. That is the FDA guidelines. Now, if the second testosterone comes low, the PSA is normal. The reason PSA should be normal is there's a theoretical reason that testosterone may exacerbate prostate cancer. No, there's nowhere been proven that testosterone causes prostate cancer, but there is anecdotal reports, and that's a complete different topic altogether. And there's a lot of controversy in the urology literature whether you can give testosterone to a person who has had prostate cancer and been treated, but that's a complete different topic altogether. So if you have got low testosterone and your PSA is normal and your CBC is important, because your hematocrit, which is the red cell count, has to be normal, because testosterone, one of the side effects of testosterone is raising hematocrit, and that's one of the called polycythemia. It raises the testosterone, so you have to make sure your hematocrit is normal. And then LH, FSH can give rise to whether you have secondary or primary. And then the testosterone level is very low, then we rule out something, we do a prolactin level, prolactin, to rule out a very rare cause of prolactinoma, which is a pituitary tumor which can compress the area which produces the hormones, tell the testicle to produce testosterone. So that is very rare, but I've seen about few cases which are diagnosed. So that's how we diagnose testosterone, low testosterone.
Any other benefits or risks associated with this testosterone therapy or the treatment?
So treatment, we actually there are various ways of treating. There are gels available. There is injection. There is a nasal spray coming out. There is the injection can be a depot injection which you give it every week or every other week, and there's an oil-based depot which you can give it much about 4 times a year, 3 or 4 times a year. So all those options are available. Advantages of a gel, that you apply it every day, but it doesn't give you the real high level. Gel's absorption is variable, so that's why gels came into the market but did not really take off that much. I don't use it that often. Injection is where the patient injects depot testosterone, either 100 milligrams every week or 200 milligrams every other week. And that gives you side effects are, it gives you some peaks and troughs. So when you get the shot, for the next few days your testosterone is very high. Before the next shot, your testosterone comes down quite low, and that is one of the side effects or one of the problems of that. So there is no right or wrong. Oil-based testosterone gives you a little bit more steady level, because you have to use it, you have to give yourself maybe 3 or 4 times a year, which is pretty reasonable. However, the cost is very high, and not many insurance companies cover this oil-based testosterone therapy. Oral testosterone is not used. FDA does not. There are a lot of people who used to use testosterone pills, and right now the testosterone pills which have been there traditionally in the market is not recommended, and they are coming up with some kind of other ways of testosterone pellets and testosterone therapy, which is still being reviewed by FDA.
What are some of the treatment options for erectile dysfunction, and how common is erectile dysfunction is in man? And is there any correlation between erectile dysfunction and any heart disease or cardiovascular risk? And last question on erectile dysfunction is there any correlation between COVID-19 and erectile dysfunction?
Thank you. That's a very good question. That's a very loaded question. I need to answer it one at a time. Erectile dysfunction is quite common. It is in a younger age. It's mostly psychogenic. But if you have a real low testosterone at a younger age, you should think of probably this patient having a high risk of coronary artery disease. The reason is the atherosclerotic plaque happens both places. Penile arteries are much smaller than the coronary arteries. So if the patient gets atherosclerotic blockage in penile artery, he may be a candidate for a cardiac disease early on. And if a patient has real arteriogenic impotence at a younger age, not psychogenic, real arteriogenic impotence at a younger age, he should be evaluated for any cardiac problems. Now, it is common, as we know, as we grow older, it becomes more and more common. What are the treatments of that? Well, Viagra actually brought people out of the closet much more than what we have ever done. Viagra is now more than 25 years old when it first came out. But before that, there was hardly any treatment options, and many people only thought that surgery was the options. They were not very effective treatments. So not many people used to come to the doctor. When Viagra came out, everybody started coming out, and we actually saw a huge spike in the incidence of erectile dysfunction, not because they were not there before, because more people came out, like I said. We call PDE5 inhibitors. Those are the pills which people take. Pills actually prevent breakdown of nitric oxide at the penis level, which keeps the vessels of the penis open and keep the erection going. So that's how that works. There are three main medications. One is Viagra, which everybody knows. It's called sildenafil, and Cialis, which is tadalafil, and then there is Levitra, which is vardenafil, which are three medications which are commonly used. Viagra, perhaps the most common one used. Second is Cialis, and we very rarely or less frequently use Levitra. Um, a problem about this medication that it works, it doesn't work in about 30 to 40% of people. It does not work. Why? Because you have to have some blood flow into the penis for it to work. Remember, I said it keeps the the cavernosum or the spongy tissue where blood fills and gives the erection. It keeps it open. Now, if there is no blood flow to it because the arteries are blocked, Viagra or any of these medication will not work. Then what do we have? Other options. Well, the other options are we used to have something called intraurethral suppository called Muse. But usually after this oral medication came into vogue, if the oral medication does not work, chances of intraurethral suppository working is low, and very few people actually use that anymore, very few urologists, but it's still out there. The third thing is vacuum erection device, which is a cylinder which you put on the penis, and it's battery operated. It by suction pulls blood into the penis, and you put a rubber band at the base of your penis, and it keeps the erection and keeps it from detumissing or erection going down. The fourth option is penile injection. There are some medications which you inject into the penis causes vasodilation or dilation of vessels, and gets the blood flowing into the penis, and that is something which the only FDA approved medication for that is called prostaglandin, which the trade name is Edex or Caverject. These are the two common trade names. But prostaglandin is so expensive that very few people can really afford it. And that's the reason there is something people use called Trimix. They use two other medications which are also vasodilators, was is phentolamine and papaverine. Those are, my interest friends know that they have been traditionally used as vasodilators. However, there is an FDA warning, and there's a package inserts in phentolamine and papaverine saying that this is not for penile injection. So if you advise the trimix, which is a combination of prostaglandin, papaverine, and phentolamine, if you advise a combination of all those three things, you need to make sure the patient is aware that we are using it out of the FDA guidelines, and they have to sign I make them sign a consent form for that, because it says that it can cause penile fibrosis and so on and so forth. Now, the last option which is there, which actually peculiarly, very interestingly, not peculiarly, very interestingly, um, has the highest patient and partner satisfaction rate. They've asked patients, they've asked partners of patients, and it's got 92 to 93% satisfaction rate, which is called penile prosthesis, or in lay terms, it's called penile implant. We make a small incision in the penoscrotal region, or various, depends on which, there are different incisions you can make. But bottom line is that you put two cylinders in the penis corporal body, two cylinders, and a reservoir is kept inside, but right next to the bladder, which the patient doesn't feel. The patient only can feel a pump in the scrotum. And when he is ready to have intercourse, he pumps it up. It is just like any bicycle pump or anything like that. It gets hard. The more you pump, the harder you get. And after intercourse is over, you can press a button and it completely deflates. What I talked about is the three-piece penile prosthesis, which is available in US and most commonly used. Then there is a two-piece penile prosthesis, which just consists of the pump and the cylinders, no reservoirs. And there is something called semi-rigid, which is mostly used, available in India. It's very rarely used here, except for spinal cord injury patients. I don't use that often. But in India, that's the most common cause, commonly used, because that's what's available indigenous there. And that is actually just a semi-rigid rod where you want to have intercourse, you straighten it with the hand. When you're done, you just fold it down. So those are the three penile prostheses, and these are the three things which is available today for erectile dysfunction treatment.
So much advances in the treatment in last few decades. Hats off to the scientists and the researchers who definitely came across with this new technology and new treatments available for this man's health actually. So Dr. Chakraborty, as a secretary of National API, the biggest physician organization in the country, you have been actively involved in providing education during this pandemic and stay engaged in serving physician community all across the USA. I want to appreciate all your service and kudos to you for the job well done. What are your final comments or take-home message for all men suffering some kind of urological problems, and how can they get help?
So thank you very much, Tushar, for those kind words. Let me just tell you a little bit about my API adventure first. Thank you for bringing that up. I have been working for API for more than 2 decades. I have been a patron member for 25 years. I have been a governing body member. That means holding some kind of API related post for 14 years. I've been the regional director in 2004, 2005. I've been president of Alabama Association of Physicians of India. I've been the president of St. Louis Association of Physicians of India. I've been the president of Indian American Urological Association, board of trustees for 3 years, and have continued to work. In addition to that, you may be interested, because I know you're musically oriented. I started something called API's Got Talent, which is one of the most coveted programs in the convention, and also something called Mehfil, which people look for, because it starts after the main program is over, from 12 o'clock to 2 o'clock, sometimes goes to 3 a.m. in the morning, where people sit back, relax on gaddis, and enjoy. In addition to that, I have been awarded the Distinguished Speaker Award. I'm in the Distinguished Speaker Club of API last year, and I'm the editor of the API Medical Journal. I've conducted a lot of webinars and a lot of virtual concerts during the COVID session, which was very tough for all of us. And this is the way we could get relief. We involve people from all over the world for these kind of conferences, and we had tremendous response. And hopefully, with your blessings, I can move on forward, and with your support. And last comments which you asked me to let you know about men's health. Few things. Number one, men usually do not take care of their health as well as women do. Men rarely come for the prostate check. Men very rarely come, because that involves a rectal examination, and that's not macho. And that's something which people have to realize, that it is, prostate cancer can be a killer. Early PSA, just checkup, is very, very essential. Erectile dysfunction is not a taboo subject. There are ways to treat it. ways to cure it. BPH, don't wait till if your medications are not working or if you have got side effects, don't wait, because there are minimally invasive procedures can be done in the office in 10. The resume procedure literally takes less than 1 minute, 9 seconds each treatment, and we usually do 5 treatments. That's it, less than a minute, and it's done in the office. So these are the things. Even if your medication is not working or minimally it's still working but not enough, or you're getting side effects of fatigue and other side effects of retrograde ejaculation, which is a common side effect of Flomax, tamsulosin, where you don't have enough ejaculation. So all those things can happen, and we can do Urolift, which has got zero retrograde ejaculation rate. So if you've got BPH, you do that. Infertility can be treated. If you have got varicocele, it is reversible. We talked about erectile dysfunction. We talked about BPH. We talked about prostate cancer. It's always essential, especially after 50, like you go and get your colonoscopy done, you need to get a prostate check and other urological things done, so that you can live a healthy life. That's all.
Thank you so much, Dr. Chakraborty, for your time and expertise in providing some valuable information to our viewers on urological health for men. I sincerely appreciate your time to come to MedTalk for interview from your busy schedule. And I wish you all the best in serving your patients and staying healthy as well. And wanted to wish you all the best for your bid for the Vice President for API in your upcoming elections coming up. Thank you so much.
Thank you, Tusharji, and thank you, Indus TV, and appreciate you having me here.